What Imogen asked me to do set me thinking, well, what's going to change what we do over the next 2-3 years? Because we've got used, those of us who trip off to Chicago at the beginning of June every year, to melanoma being the headline act there. And this year was a bit of a quiet year compared with some years, but there's still stuff happening. Things are going to change fundamentally. So just thinking about what's going to make a difference in 1 year's time, what's going to make a difference in 5 years' time, what's going to make a difference in 10 years' time. And, the thing that's going to make a difference in 1 year's time probably is injectables. Treatments that you inject straight into the tumour. So we know about TVEC, it's out there, it's licensed, it's used, albeit not very often, to treat melanoma at the moment, particularly if you've got lots of little lumps on your leg or your arm or something like that. But we don't want to go in with the intravenous drugs. And there's a big trial running which will read out in about a year's time, I'm guessing, I'm not part of the study, which will sort of test whether you can use the TVEC by injecting it into tumours to make what we call cold tumours that are insensitive to current immunotherapy, hot and then sensitive. And there's quite a lot of reason for optimism with science that I won't bore you with. But if that trial works out, then it's going to create a whole new specialty in hospitals up and down the country of specialist virus injector. At the moment, we do it when we can see the lump on the skin's surface, but there's absolutely no reason why, with the aid of an ultrasound probe or a CT scanner or an MRI scanner, we can't get at quite a lot of tumours. There's a very famous medical book that claims there's no part of the body that can't be reached without a strong enough arm and a 14-gauge needle. Most of the rest of the book is eminently forgettable, so I won't give you the title. But it does hold out the prospect for another radical shift in the way in which we look after people, the way in which we approach treatment, because it'll mean bringing in colleagues who are expert in placing needles just in the middle of tumours, not just to take pieces of tumour out, which as a scientist I'm very, very interested in and looking at that in the lab, but also about putting treatment in and changing the way the tumour behaves so that we can use that with immunotherapy. So I think that's the thing that's going to start radically to change practice in the near future. Looking slightly further ahead, we know, and the discussion that Paola chaired a bit before lunch included mention of adjuvant treatment, we know that if we can get our treatments in when there's not so much melanoma about, they're more effective. We tend to get about half as much, again, the benefit if we can do that before the tumour gets too big. So taking that further, what about if we start that treatment when we can't actually see any tumour? Now, that's a little bit what we do with adjuvant treatment, but for people who know people who've had blood cancers, there's long been the concept of molecular relapse. So you can't see the cancer, you can't pick it up on a scan, however fancy you do it, but you can detect the molecular traces of it in the blood. And I talked a bit about that last year, the ctDNA tests and things like that that are coming through. And there are more and more sensitive technologies that are being applied. And there are some trials like PIPAs with BRAF drugs that are starting to make use of that technology to monitor what happens on treatment. But I think the big change that's coming over the next 5 or 6 years, potentially, is to use molecular relapse rather than clinical relapse as the basis for starting some of the drugs that we know and love and use today, in the hope that that will increase the cure rate, will mean that we can give treatment at a time where people don't have symptoms from the melanoma that's on board, therefore can cope with it better, so that all round it's a better outcome and an easier experience. And there are a couple of clinical trial programs that are going to start over the next year or so that will start to test that out. It's happening right across cancer, in breast cancer, in bowel cancer particularly. And I think that's going to be another very, very big change, potentially, but with a slightly longer horizon. And then, looking even further ahead, and at the risk of sounding like I'm jumping on a very, very large bandwagon, the thing that I think is most likely to change what we do over the 10-year horizon is artificial intelligence. I can hold about 3, 4, on a good day, 5 or 6 different pieces of information about the situation in my head simultaneously, try and map them all together and say, okay, that tells me what to do in this situation. A computer can do that with thousands of pieces of information. In the lab now, if we look at a tumour, we can generate those thousands of pieces of information. So using machines to sift through them, to decide what's important, to decide what tells us how best to use current treatments, future treatments, what the vulnerabilities are, whether it's a good idea for an individual because of the risk of side effects or not, is coming through. We're starting to see that in terms of diagnosing melanoma. There's a computer algorithm in California which makes the average dermatologist as good, well, not quite as good as the best dermatologist, at diagnosing a melanoma from spots on the skin, for example. On one level, that's really reassuring. The best humans are still outperforming the best computer, although I suspect that a bit like chess in the 1970s, that's going to change quite quickly. The reason that the AI is important, though, is that AI will only make a difference in melanoma management if all of us engage. With the other bits and pieces, it's the sort of thing that the medical teams, the nursing teams, the researchers can get up to and do. If AI is going to change medicine, it's going to be because the whole population, all the patients who are involved, their families, get engaged. Because the way that AI works is that what you feed into it educates it. So if you teach it better, you get a better outcome. And one of the things that we're exploring at the moment is how you make sure that if we're going to have AI in looking after people with melanoma, is how we give the computers the best, the most complete information set possible to train them accurately and make sure that they do a really good job before they're unleashed into the clinic and make people like me redundant. I'd retire in 13 years' time, so there's no hurry, guys. So part of that, and we'll be reaching out to you, I'm sure, in the coming years, is about citizen science. We have to move away from this idea that ivory towers like mine in Oxford it's actually green with the sort of dodgy cladding that you had at Grenfell Tower, but we're going to change that, are the places where we do all of this and get it out there and say, okay, what we're going to need you to do is to tell us about yourselves, to put that on, basically do what Google does, basically do what Amazon does, which is rather than, try and extract your information out of hospital computer systems that basically give up data only on pain of death, and get you to tell us about yourselves in the way that big tech does at the moment, because then we've got your permission, we've got your engagement, you can decide what to tell us, what to leave out. We can then link that with the sort of biology bits that we really want to understand how they shape what happens in real life, not in lab life, and then bring that all together. So those are the 3 things that are sort of getting me up in the morning and thinking about how we can change practice.